Ben arrivati a questo meeting.
Welcome to today's meeting. As you know, we're here to talk about migraine and headache. This is a social pathology with a high impact, and it is often underestimated. I would like to thank Beatrice Lorenzin, Honorable Member of Parliament and former Minister of Health, Andrea Costa, State Undersecretary at the Ministry of Health, Antonio De Poli, Questor of the Senate, and Alfredo Berardelli, as I am President of the Human Neuroscience Department, full professor at Sapienza University of Rome. He's also Director of Human Neuroscience Department, UOC Neurology, and the Psychiatric Polyclinic Umberto I in Rome. Then I would like to thank Paola Boldrini, Vice President of the Permanent Commission for Hygiene and Health, Fabiola Bologna, the Affairs Commission at the Chamber of Deputies, and Aldo Patriciello, Deputy of the European Parliament. My name is Claudio Zanoni, and I'm the Scientific Director of Motore Sanita. And then there is Cristina Tassorelli, President of the Scientific Committee, CIRNA, Neurology full professor. Then Anna Ambrosini, Head of the Center for the Study and Treatment of Headaches, IRCCS Neuromed. Piero Bermanti, Head of the Headache and Pain Treatment and Research Unit at the Department of Neurological Sciences, Motor and Sensory at San Raffaele in Rome. Paolo Calabrese, Head of Neurology Foundation at Gemelli in Rome. Licia Grazzi, Head of the Headache Center, Neurology 3, IRSCCS Foundation, Carlo Besta Neurological Institute of the Lombardy Region. Paolo Martelletti, Associate Professor of Internal Medicine at the Regional Center for Director Sant'Andrea Sapienza University of Rome. Then Helena Ruiz de la Torre, Executive Director and past President of EMHA, Lara Mereghi, Councillor of CIRNA, Daniela Moruso, Alessandro Malpelo, and Claudia Altamura, Neurologist, Headache and Neurology Unit at the University Hospital of the Medical Campus of Rome. Bernardi, Carlo Borghetti, Vice President of the Commission of the Lombardy Region, Francesco Castellucci, UCH Councillor, Cinzia Finocchi, Coordinator of the DMT cerebrovascular diseases at the San Martino Polyclinic Hospital in Genoa. Alessandro Giua, Vice President of OUCH Italy, Pierangelo Geppetti, Headache Center and Clinical Pharmacology at the Hospital Careggi in Florence. Now, Franco Glanella, Vice President of the SISC and Professor at the University of Studies of Parma. Lara Mereghi, I've already mentioned her. Then also Cristina Tassorelli, I've already introduced her. So I'd like to start with a video of the Motore Sanità to introduce the topic of today's meeting, so migraine and headache and their implications. And then we can start with Honorable Member of Parliament, Beatrice Lorenzin, who is going to, bear testimony also as a patient, as well as a former Ministry of Health. Here is the video.
L'emicrania è una patologia molto diffusa ed invalidante.
Migraine is a very widespread and disabling disease affecting about 11 to 12% of the world adult population. It's 3 times greater in women. It is considered an important public health problem because it has a strong impact on the quality of patients' lives, but also on the direct and indirect costs of the society. It is not a symptom, but a neurological disease representing the 3rd most frequent pathology and the 2nd most disabling pathology of mankind, according to WHO. Migraine today is one of the neurological diseases on which the greatest number of scientific knowledge is available, not to mention several specific and selected effective drugs. However, it still remains non-treated and underestimated disease. It can be compared to a severe atmospheric disturbance that can be repeated several times a month and can last for several days. 24 hours before the worsening of pain, people can feel symptoms such as fatigue, irritability, depression, yawning, and a particular appetite for sweet foods, including chocolate. In 30% of subjects, the painful phase is preceded by this so-called aura, a focal neurological symptom. It can last from 4 to 72 hours, and the pain, which affects half of the head, is throbbing and exasperating. All other symptoms also become very strong. The ones who suffer from it have a suffering posture and need to be isolated from noise and light, so the world around them. After the acute phase, there is a post-drome phase, which lasts another 24 to 48 hours, with impatience, frustration, mood, depression, and migraine is considered episodic if there are up to 14 episodes a month. Chronic when it occurs for more than 15 days a month. But every year, 2.5% of patients with episodic migraine evolve to a chronic form of migraine. It is a family neurovascular disease with a likely genetic basis. A migraine patient's brain is hyper-excitable but hypometabolic, so it spends more energy than it produces. It converts stimuli such as stress, climate changes, sleep-wake irregularities, female hormone variations, and it is frequently associated with other pathologies: affective spectrum disorders, epilepsy, chronic pain syndromes, allergies, asthma, and circulatory diseases. Migraine has a severe impact on daily activities, especially on women. 28% of female patients, compared to 18% of male patients, reports having lost more than 10 days of activity in the last 3 months, and these are EU data, with productivity at school or work reduced by almost 50%. Furthermore, the lack of social attention to the problem leads to a stigma perception of the disease. 33% of patients are actually reluctant to disclose their problems to others. It is estimated that a migraine has an economic cost of 111 billion euros per year in 27 European countries. 20 billion, 80% of the cost, are only related to 4 countries, that is France, Germany, Spain, and of course, Italy. These are direct costs, such as medical expenses, tests, or purchase of medicines, but above all, indirect costs, a loss of school or working days, a reduced productivity, but there are also less tangible costs. They are psychosocial costs linked to pain, anxiety, and the emotional impact that the disease can cause on the affected individual and their families. In some cases, just a few in Italy, between 0.1 and 0.3%, it can even lead to committing suicide. Thank you for your attention and welcome to our event. So, this is not just, something funny, the virtual reality, because you can think of what is happening, of what is being done, on the fact that people can take part in events from Australia and every part of the world. So this was just a performance, but there are others that can be used and that can be effective. I don't know if Beatrice Lorenzin is online. Not yet. Okay, so I would like to ask Andrea Costa, the State Undersecretary, or Antonio De Poli. They are not here yet. Okay, so can Mr. Berardelli introduce the subject of migraine. Well, the last time we met here in Rome, his support was fundamental. So can you please tell me when the other speakers arrive? And I would like to remind you all that we are on Zoom and Facebook. How many people? 342 on Facebook and 115 here. So there are more than 400 people with us. So thank you. Thank you for inviting me. I would like just to add a few words and give you a message. The Italian Association of Neurology, with over 3,000 neurologists all over Italy, well, is an association that is working hard to fight and deal with migraine. There is a special group in our association which is devoted to studying headache in its various forms. So let me just say that this is a priority for the Italian neurological sector, because migraine is a neurological disease, and there is still a lot to be done, both in terms of awareness about what migraine is, and also in terms of scientific research. We were very proud to see that new drugs were launched, which changed the approach to patients as well. So our association totally supports all the initiatives that aim to raise awareness on this disease, which is a profound social disease with a strong impact on the society and on our working and everyday life. So I'm sure that the next speakers will be able to give us a complete framework of what I've just mentioned. Thank you. Thank you, Professor. Thank you very much. Fabiola Bologna is with us. She is online. Good morning and welcome back to Motore Sanita. Yes, good morning. Fabiola, I know that you have some slides that you would like to share with us, so please, you can go with that.
Scusate un attimo.
I mercati generali spinge il cuore e il governo ha il dovere di porre rimedio a questo scempio della nostra società. Grazie. Chi non si può trasformare la lotta per richiamo, si tratta di aiutare imprese e cittadini.
Non so se vedete le diapositive.
I don't know if you can see my slides. Yes, if you can. Activate full screen mode. I don't know if you can ask Laura to stop for a while. No, I'm sorry, I can't. Well, you have already said some of these things. My presentation was in between my activity as a neurologist and my activity as a member of parliament. And it's clear that, as you said, headache is one of the most common forms of pain. And it is clear that the Migraine Research Foundation estimates 1 billion patients in the world. So this kind of disease has a strong impact both on psychological health and quality of life of patients, and it has very high costs in terms of human, social and economic resources. In Italy, we spend about 3.5 billion euros per year, so it's a very important amount. This sequential multi-phase process means that this kind of disease has different phases. The first one is a prodrome phase with symptoms before the pain arrives. Then there is the aura, which is the neurological phase that can really scare the patients because they can have some sight impairment or other symptoms preceding the headache itself, then the pain itself and the post-drome phase with other symptoms that can have an impact on the quality of life of the patient. One thing that we should underline is that this is a gender-related disease because it affects a lot of women. They suffer from it 3 times as much as men. And their clinical frameworks and the clinical situations and conditions are much more complex and disabling than men. In Italy, the Ministry of Health has worked on this and on starting the differences between also the pharmaceutical treatment needed for men and women, because they can have a different response to this kind of pathologies. And in particular, in terms of headache, there are strong differences. Then there is the concept of stigma, and I think that you will deal with that later on today, because you know, the headache and migraine are like trivialized, are considered as something very normal, whereas they are very disabling. And we also thought of setting some general guidelines for disabilities due to migraine, but the ministry hasn't got to that yet. Generally speaking, talking about the condition of the patient, well, they generally feel alone, and they deal with that on their own, trying to find the right drugs, but their quality of life is extremely compromised. And then the final result is a debasement, suffering, resignation, and very often diagnostic tests cannot get to clear diagnosis. So the most important thing is to inform people, to raise awareness of more people, and also tell patients that they should start from the GPs, the general practitioners, and then get to the local neurologists and the local centers to find the most efficient treatment methods. There have been a lot of important steps forward to reduce the suffering and to improve the diagnosis for a lot of people, and other speakers will talk about that. And as I said earlier, there are new and different drugs and support activities such as individual psychotherapy or psychodiagnostic evaluation, biofeedback, and relaxation or mindfulness that can help the situation of patients. There was a law in 2020, the law number 81 of July 2020, talking about the recognition of primary headache as a chronic social disease. This was a long path that required our attention, that was considered in particular in our Senate. And this is very important for our country because it's the first time in Europe that a country recognizes headache as a social disease. But now we are still waiting for decrees that actually implement the law, in particular to identify projects and new methods to take care of the patients. But these decrees are running late. And so I actually demanded to the Ministry of Health what kind of initiatives will be implemented to be in line with the law 81 of 2020 in order to protect the right to health of all the patients suffering from headaches and migraines. So this is a commitment that I share with all the other colleagues in the Health Commission, and I hope that the Ministry of Health will give us a response as soon as possible. Thank you very much. Thank you very much to Fabiola Bologna, not only for her hard work as a professional, but also for her institutional presence, since she is fighting on this point and also on other rare diseases. So thank you for what you do. I would like to call Aldo Patriciello from the European Parliament to join me on stage now. Thank you. Thank you to EMHA for organizing this moment to share ideas and to deal with such a problem such as migraine, which is extremely important and complex, but very often this is, trivialized because it's just a headache and institutions do not pay enough attention to that. I would like to thank all the colleagues that are with us here or online and all the guests of the scientific panel that have enriched the discussion and are enriching our discussion today. Being a component of the Commission for Research and Health, I've always welcomed what arrived from EMHA on this topic. And for this reason, in the course of the year, we organized several events in Brussels and Strasbourg to raise awareness among institutions and European institutions, as well as national institutions, on a topic that is often underestimated, but that represents the third most common disease in the world, affecting 136 million of European citizens and more than 1 billion citizens in the world. So migraine is a disabling disease, and it gives nausea, vomiting, hypersensitivity to light and noise, and this is why it has a very strong impact on the life of people. There are also important social repercussions, both in terms of healthcare and assistance, and in terms of loss of productivity, with direct and indirect costs that, according to recent studies, are about 27 billion euros, considering both medical consultations and the loss of working days. In order to reduce the symptoms and improve the conditions of patients, it is important to increase research. Several clinical trials have been funded, accounting for 1 billion euros, and this allowed to better understand the brain functions, improve diagnosis, the prevention and follow-up. New biotechnological medicines have been developed based on genes or cells, offering extraordinary opportunities for the patients. This is a therapeutic revolution based on the use of monoclonals that have been developed and studied ad hoc. In January, the European Commission authorized the use in the European Union of the monoclonal for the prophylactic treatment of migraine for people who suffer from at least 4 days of migraine per month. So I really welcomed the idea of raising a European debate on this topic to increase the visibility and the awareness not only among people, but also among European institutions. Italy, with the law of last year recognizing the social impact of migraine, shows that it is one of the most advanced European countries in the treatment of chronic migraine and its recognition, but it also underlines the need to keep on doing more and more. We are working on a roadmap founded on 3 main pillars. First, making migraine a priority so that it can be included at the European level and considered as a gender-related issue. Second point, financing the research on migraine. And number 3, strengthen the alliance against migraine at the European Parliament and integrate migraine into the European health agenda. Following the example of Italy, all countries in the world should start supporting migraine and its treatment, going beyond government politics and the stigmas surrounding migraine. We should recognize migraine as a European disease, and that's the first step forward in dealing with the impact of migraine, and that's the right time to change. Being a European member, a member of the European Parliament, I will do my best to encourage institutions to do more and better. Thank you.
Allora, io so che è collegata.
I know that, well, thanks to Aldo Patriciello, I know that Rossana Boldi is online. Good morning and welcome back. Good morning, everyone. The floor is yours. Thank you for inviting me. And thank you for raising this problem and this debate around migraine and headache. Because as other speakers have already been said, this is the second cause of disability, but so far the healthcare policies, both in Italy and in Europe, haven't been effective enough, or they haven't dealt with it very clearly, because migraine hasn't been a priority so far. And other speakers have already underlined it. Well, apart from personal costs in terms of stigma and suffering, this disease has very high social costs. Considering the number of women who work and need to live with migraine, it is very important to give them the right access to healthcare and treatments. And considering that women are the most affected subjects, it is important to pay the utmost attention to them in order to ensure gender equality in medicine too. So this is once again a core topic. In 2020, the European Parliament approved a law. It's the Lazzarini's law. And Honorable Lazzarini says hello to all of you. And this law aimed to see migraine recognized as a social disease, a social malady. But our ambition was actually different. We wanted it to be recognized as a chronic disabling disease and be included in among those diseases, because, you know, there are several facilitations, several incentives, so to say, that are enshrined for these kinds of diseases, of disabling diseases, but we weren't able to get to that due to the Ministry of Economy and Finance in particular, because they told us that the costs could not be managed totally. But meanwhile, other drugs, medications have been developed, and they are provided by the national healthcare system. So this is a step forward. But still, there's a problem that should be dealt with by our politicians. This problem is that, well, there are a lot of centers in Italy for treating headaches and migraines. However, there is no equal access to these new treatments and drugs that can only be distributed in these centers. So some patients' associations showed that, well, there should be over 200 centers taking care of patients, and then, if needed, administer the drugs. But out of these 200 centers, only 70 are actually working. This means greater difficulties for the patient and greater difficulties in the integration of what the region and the national healthcare system do. So I think that it's important to facilitate access to these kind of medications and treatments for patients. And then we should involve more actively and inform more carefully general practitioners, family doctors, because, you know, very often when a patient goes to them, they underestimate the symptoms. They think that it is just muscle migraine due to tensions, and they do not immediately treat the patient in the right way, following a specific path towards the most suitable therapy. This is why this kind of knowledge should be very important and be achieved by raising awareness with family doctors and with the population. In this case, to deal with the stigma that we mentioned earlier. Because it is easy that these people are like discriminated or marginalized because, you know, very often they are told it's just a headache, you don't need a specific treatment. Instead, it is very often a neurological disease that must be treated. And not just with drugs that deal with symptoms and not the disease itself, whereas now there are new biological therapies that can halve the attacks, migraine episodes, and can help people have a more normal life, go to work, have a social life, a good social life. I think that the politicians should be committed to that and work on that. Thank you. Thank you very much to Rossana Boldi for her commitment. Now, Paola Boldrini, Vice President of the 12th Permanent Commission of Hygiene and Health, and I would like her to give her presentation. Thank you. Thank you to our Senator. Can I take off the mask? Yes, yes, absolutely. Thank you. Thank you for this initiative. Thank you for, you know, focusing on migraine because, well, I know a lot of people suffering from that, and I know that there are really plenty of people in the world, and most of them are women, as our colleague said, and this is a strong variable to consider. I think that the world of women is the one that suffers the most, and this disease should be recognized as Mrs. Boldi said. The law 81 of 2020 aimed to make this disease recognized through a series of tests that should be performed by a recognized center for headache. So this is my role, and I'm here as a representative of the institutions. As you know, the law should be important to identify these centers with projects to take care of patients.
Però voi lo sapete, i decreti attuativi spesso hanno vite molto più lunghe e quindi i decreti attuativi devono essere aiutati.
So, you know that these decrees have to be helped and even sponsored, as you know very well. So this decree, as of today, is still, let's say, invisible. I mean, I don't want to justify this, but the law dates back to 2020. We need to wait 180 days, but you know that we had COVID. We still have COVID, and there are also, I mean, other, you know, problems again. So I'm sorry to say that there are no limits to what is happening. So my colleague has presented the so-called question at the Italian Law Chamber. I'm sure there will be an answer. I am in the other side of the parliament. I'm sure there may be another set of so-called question times. There's something which is even more important to do. I mean, we need to really talk to regional authorities. The reference centers or the hubs are not very many. So also regions should activate the opening of these centers so that we can really avoid, you know, the so-called health mobility that we know very well. If patients know that in a hub they have received, let's say, the right take-up, well, of course, people are highly motivated. Of course, we know what a headache means. We don't want to have it again. Those having this pathology, unfortunately, this is periodical. Quality of life is fundamental and important, especially because when you have this type of problem, you cannot do all the rest. So just think of women and, well, even more so, because of course, children, parents, job, housekeeping. Now, this is our engagement in terms of politics. We need to take into account this decree together with the regional level, because this is also important. There's another thing I'd like to say. There's a sort of a comparison with Europe, which is really very important. You know, sometimes we have norms or standards which are better than what Europe is doing. For example, there's a national plan that, well, this is an all-Italian best practice, if you will, and people don't know this very well. I have to tell the truth. For example, back in 2016, the plan has been approved, it's been ratified, but some regional authorities have not implemented it. The National Plan, NP, is a very important tool. You can see that this is a pioneering effort, and this is the basis of the so-called version 6 of patients take-up. I am in the Health Commission, so we take into account the so-called issue number 6, and this comes from the National Criticalities Plan. So everything is done to consider all these needs. The take-up of the patient at home, well, this means that the patient doesn't have to rush to specific places, but from their, the place where they live, or the so-called community centers. I am also included into the chronicity group. So I co-participate. I mean, together with Mr. Provenza, we decided to create this so-called intergroup. So it's a working group. We put together 1.5 years ago. So we work with those associations with chronic pathologies. So also headache is a chronic disease that over time, comes back again, over and over again. So we have cooperated with an association of headache patients. This can also be included into the national plan, so as to understand exactly what to do, apart from what the law has done. Something very important has been done, because we have recognized a social illness. Of course, we wanted, to see that this disease is sort of an invalidity or a handicap. So once again, we need training. There's a continuous flow of innovation in medicine and scientific research. So also general practitioners need seamless updates. We have new therapeutical responses. I'm not a doctor, but this is what to say. This is also another topic that has to be taken into account. So this is my commitment today. First of all, we keep listening. We will face the decree issue. So once again, we may want to present another set of questions at the Parliament. We need to cooperate with regional authorities. And as I said before, we also need a sort of a European benchmark, because many other European associations may do something for us. They may be an example for us. So it is really, really very nice to also consider European innovative experiences, because this is do ut des, as we say in Latin. So we can do something for you, and you can do something for us. This happens in scientific environments. It can also happen in our associations. This is what we are doing with associations that are taking care of cancer patients. So important topics that have to be shared with those countries that we cooperate with. So I have to say that we have to work together in Europe, and the example was China. Because of the pandemic, we merged efforts, we joined efforts to find responses. This is an important means so that we can offer answers, or we can borrow answers from other countries. So we need to help this population, because these people, have to have answers. Okay, so hopefully we will be able to give other answers to meet the needs of patients. So what they want is health. Okay, this is it. Thank you.
Grazie, senatrice Boldrini. Ha ragione lei, il piano nazionale.
Mrs. Boldrini, thank you so much. You are right. I mean, we have the National Chronicity Plan. We have talked many times about this. The only problem of the Italian plans is that they have to be helped from the financial point of view. So hopefully also for migraine, there will be the right financial support, and hopefully even general medicine can be involved directly with the right information. Once again, thank you. Thank you. Okay, we have 504 attendees. I mean, including Zoom, Facebook, and you attending here. So this means that the migraine is a key topic. Under Secretary Costa will join us later. We don't know exactly when, but he's involved in COVID, and then Ukraine. Of course, all of our thoughts go to Ukrainians. Also, Mrs. Lorenzin will connect later. This is a short scenario introduction. Then I will give the floor to the other speakers.
English language. Allora, possiamo andare avanti con la prima.
Okay, then, slide number 1, please. In Italy, migraine patients are 12% of the population, as we said before, 15% with more than 4 episodes a month, 5% miss more than 5 working days a month. So migraine is sort of a handicap because it has an impact, social impact. It also has an economic impact. Main categories, as we said before, are, the migraine with aura, the migraine without aura, respectively 15 and 85% of cases. As for the organization in our country and other European countries, as for migraine and headache, we have association with the so-called first level centers, second level centers, headache centers with hospitalization possibilities. We have to say that all these centers, well, actually, we don't have many which are up and running on a national level, and this is a long problem in terms of waiting list. Strong research efforts unearthed very many effective therapies, so NSAIDs and monoclonal antibodies. As for the state of the art, now I'm talking about the possibilities we offer now. So, as you said before, EMHA, the European Migraine and Headache Alliance, produced a survey with new ideas that have emerged. This is an exchange of best practices on what is missing and what we can do to improve health services. One of the objectives of this meeting is to share the results of the survey. It is a fundamental tool to know what is missing. We will do this in 4 different bullets. The commitments of Italian institutional representatives on migraine from Europe to Italy, epidemiology and social medical impact in Italy, that we will see in the next speech, therapeutic gold standard and cost-effective analysis of innovation, disability in chronic migraine is point number 4. We have plenty of commitments from Italian institutional representatives. Within 180 days of its entry into force in July 2020, we should have adopted a decree, but then we had COVID. The pandemic froze plenty of processes, not just on migraine. But now the point is, how can we make this law effective? And what can regions do in order to have innovative methods? As for epidemiology and the social medical impact in Italy, we know that the impact is due to direct costs, and 93% of costs are attributable to a reduced productivity. The therapeutic gold standard and the cost-effective analysis of innovation, we need to differentiate, to single out the types of migraine. We need to improve the so-called DP, so the doctor-patient communication with a personal approach. We really need to talk about the precision or personalized medicine. We need to improve, as I said before, the flow of communication. We need to create a regional network, and inside the Italian Neurology Society as well, the president told us that migraine is one of the key topics in their scientific actions. Chronic migraine is a big issue, in some cases up to suicide. This means everyone in all the Italian regions, we have to have innovative therapies. As for disability in chronic migraine, we need to highlight the criticality of a disease. This is not common headache. It causes distinctive illnesses and disabilities. And then we have to overcome the underestimation of pathologies, such as common depression, anxiety, or headache. This is a fundamental role in order to keep the institutional process going on and then teaming up with all of the players of the system. So today we're talking about strengths and weaknesses of the system, the organizational model, but also the healthcare accessibility with regional differences. We know there are differences and we need to bridge the gap. We need to take charge today by intensity of care. We also have tasks and functions. I mean, who does what in the current chain, info and communication, and the value of therapeutic innovation for patients. So, for all of these reasons, I'm inviting Professor Cristina Tassorelli. Thank you so much. We are now ready to listen to your presentation. Thank you. Thank you so much for your presentation and introduction. I really would like to thank the promoters of the event. I'd like to thank the organizers and participants. I'd like to thank politicians. Thank you so much for working for this cause, which is so important. I'm also represented an association, Headache Patient Association. I'm also representative of an international society. Well, I became president thanks to the excellent work that we are doing in Italy with many of my colleagues here in terms of research and assistance with primary headaches and migraine. So I'd like to talk about the epidemiology and social impact of migraine. Now, many things have been said already, and I think that my task as a medical doctor, well, we need to think of large numbers, so to say, but we also have to bring about change. So, 1 woman out of 5 suffers from migraine. So, me and possibly someone else in this small group. Also, men suffer from migraine. I have some male patients with a big impact, and also children. Sometimes it stays for the rest of their life, sometimes it goes away. 1 family out of 4, we have at least 1 person suffering from migraine. So, what is migraine? It can be very severe, or it can be a little lighter. So, we have the episodic migraine. This means less than 15 days a month, and chronic at least 15 days a month with headache, and at least 8 has the migraine features: intense pain, pulsating, disabling pain, limiting the activities of the subject, much more than pain, nausea, vomit. They can't tolerate light or noise. For some patients, pain is not the most disabling factor. In many cases, it's nausea. In some cases, it's the light. This can happen in many different times and modes. So you can see 3, 4, let's say, attacks, as you can see here. If you go down right at the center, this is a high-frequency migraine, so 8 to 10 days a month. Sometimes they have intense attacks that last some days. Then you have chronic migraine. Attacks may be strong or weak, but they say, I never have my head free. So when I am headache-free, I just celebrate because it never happens. This is the evolution of migraine. It is a chronic disease. We don't have many patients saying it has disappeared, or maybe yes, but after 40 years. You can see stable forms, fluctuating forms, worsening times, improving times. We have the so-called progressing systems or forms. We have episodic migraine, and then frequency goes up, then it becomes chronic. Now, this slide represents the disability of patients. We have scales to quantify disability. The one on the right, this is the MIDAS. This is the migraine disability scale. It takes into account many parameters, for example, the patient who cannot manage his or her daily life, and then he or she cannot go to work, or they go to the office, but productivity is not very high. And then absenteeism. So once again, this is a word I don't like, but patients with migraine, of course, they want to go to the office, but they fear they cannot go. So absenteeism as a word, well, I don't like it. Anyway, maybe you don't see here clearly, but the darkest parts of the columns, this means a severe or moderate disability. So you can see the low frequency migraine, then you have the high frequency, and then you have the chronic migraine. So there's a growing number of disabilities. So this is another factor that we take into account. I mean, I'm talking about neurologists or migraine specialists, the increase of frequency. When patients, start experiencing an increase of frequency, we fear they turn into chronic patients, and this is well grounded. So if the frequency goes up, well, at the same time, you have a higher risk of developing chronic migraine. You can see here, the risk is something like, 5 times, 10 times, 15 times more to become chronic. This includes the Italian situation. We don't have data on Italians, but we know that migraine is a global disease. Maybe some epidemiological variations, but very small changes. This is from the Eurolight trial. Migraine also strikes even when it is not there. Many patients are not free from migraine when they don't suffer from it because they are very anxious, they keep fearing that migraine will come back. And sometimes they are not totally symptom-free between different episodes. You can see here the financial impact of migraine. Sorry, the font is very small, but on the left, this is a sort of a breakdown, so a snapshot of the costs. You have office visits, and then you have the emergencies visits, the cost of hospitalizations, because, some patients have to be hospitalized. This is what happens, and what you can see here on the left. In this case, you don't see how many, days of work are lost. So there's a positive note on the new drugs. Look at the picture on the left. You can see here Germany, Spain, France, and Italy, if I'm not mistaken. So check for the columns, on the bottom. So pink is the cost of the patient that doesn't respond to the treatment. In blue, you can see responders. So we want to improve their quality of life, allowing them to go to work, having a full life, so to say, taking care of the family. This is a major reduction of, look at this, halving. So major reduction of, these impacts. We talked about the epidemiology. These are large numbers. Some patients are non-responders, so they don't respond to drugs. You can see here a group. We have two Italians, Mr. Martelletti, for example. Anyway, you see here the definition of patients non-responding. So they failed many treatments. But we also have refractory patients. They don't respond to new therapies. It's a small number, but it's a big issue because we can't say we have tried everything and there's nothing left. There's always something we can do. So this is an interview published some months after the law, so migraine as a social illness. We talked about the data, we talked about the delays. I wanted to show this to you because you can see here the social illness definition. Maybe it doesn't fit migraine because they say significant incidence of lethality and mortality. Now, migraine doesn't kill, but migraine, let's say, cancels life, days of life to our patients. So this step is most welcome. If I'm not mistaken, we started this in 2003. It's taken 17 years, maybe more than this. I'd like to thank the representatives of the political scene. Thank you for what you have done. It takes years, but what matters is to reach the target. Thank you so much.
Grazie, professoressa Tassorelli.
Thank you, Professor Tassorelli. Your presentation has been very important because you have pointed out very clearly what kind of problems are related to this kind of disease, of this kind of chronic disease. Now, I think we can move to the second part of the program. So migraine therapeutic gold standard and cost-effective analysis innovation. So I would ask Anna Ambrosini to get on stage, to join me on stage.
Allora io la metto dopo la professoressa, prima la professoressa Grazzi.
Okay, so Professor Grazzi will go first. Okay, so Professor Licia Grazzi. Please, you can both come on stage if you want and sit down here. Okay, the microphone is on already, everything is set. So I think we can share the slides of Professor Licia Grazzi. Medical doctor. Thank you for inviting me. So far we have listened to very interesting things, details, and I think that we are now in a better position than in the past because we can think, we can speak with higher awareness, especially in terms of impact of this disease. The concepts that have been mentioned today, and I hope will also be dealt with in other debates, are the concepts of standard of care or gold standard. I looked up the definition of gold standard. This is the best we can offer the patient. So a specific treatment for a particular condition, the best possible treatment. But I think that maybe so far we haven't looked for the gold standard for migraine, but only a standard of care that is, you know, general or specific treatments that were already used in other conditions. I think that we can be happy and proud of this turning point that has occurred, the fact that the consideration of migraine has changed. As we have already said, migraine is the third cause of disability in the world. And as Steiner said, migraine is the first cause of disability for people under 50. This is crucial to consider because it means that it affects the quality of life and the lifestyles of younger people who are more active, and again, women in particular, so affecting also family lives. It's a very complex disease with aspects that are biological, psychosocial, and social, and they are all closely connected. The important thing is to consider all these aspects together, because otherwise we will carry out a less effective therapy. So there are several things to consider when dealing with migraine patients, especially with younger patients, children and teenagers. As Cristina Tassorelli underlined, this disease is a multifaceted disease because the same patient can go through different changes. The migraine can be chronic or become chronic, or be a high-frequency episodic migraine. We need to consider this whenever we deal with the patient. This is very important because in accordance with the different phases of the disease, we need to target our medical treatment. What is the scenario? The scenario has been enriched with new drugs, new medications. In the past, there were valuable solutions, but they were not specific. Now, luckily, there are particularly advanced therapies that are more specific. And in particular, in the course of the last 10 to 15 years, we focused on particular therapies such as non-invasive neuromodulation. These techniques are less invasive than what were used in the past. Surgeries were, most expensive, more demanding, whereas now we can use devices that are very user-friendly, easy to use, and that can be used also on the most fragile, vulnerable, and younger patients. The prophylaxis, the prophylactic treatment is something important that we need to deal with any time in our clinical practice. And we know that over 83% of the patients that we treat and that initiated a preventive treatment very often drop off, and so they stop taking medications and they do not complete the preventive treatment. They lack trust, they lack confidence, they don't want to use drugs anymore. But when migraine is chronic, it's very difficult to find a solution. In the last few years, new innovative therapies have been developed. They are very interesting and they are very promising with very encouraging results. This happened all over the world, not only in Italy, but in particular there were real-life studies, and a lot of colleagues who are here are carrying out these kind of studies now on drugs that are really promising and they are safe to use. Also on very young patients and children. My last slide So it's about the three take-home messages that I would like to leave. The disease is very complex, is very difficult to deal with. Several aspects are involved and closely related one to the other. The therapeutic support and approach should be very flexible and integrated in order to reduce social costs and improve the lives of our patients. The new drugs are very promising and they reduce, let's say, problems related to costs. But as Cristina Cattasorelli said earlier, we need to consider that this can also reduce indirect costs. These new medications can really help us to help reducing all the indirect costs and for sure improving the lives of our patients. So thank you. Thank you, Dr. Grazzi. And now Dr. Ambrosini, who is the head of the Center for the Study and Treatment of Headaches at Neuromed of Isernia. Thank you. Thank you for inviting me. So far, we have talked about the strategies available so far, but I would like to, talk more about the past rather than the new treatments. As Dr. Grazzi was saying earlier, the gold standard for migraine doesn't exist. We have a sort of therapeutic weapons that we have had available so far until, the new medications arrived. And according to the guidelines of SISC of 2012, the Italian Society for the Study of Headache, and the recommendations of EFNS of 2009, there are several kinds of drugs that can be used for the treatment of migraine, such as some beta blocked or some antidepressants, such as amitriptyline and or other kinds of drugs, propranolol. And in green, you see those with the higher scientific evidence, in yellow average, and in orange low scientific evidence. So scientific evidence does not mean that the drug is more effective, but only that there are enough studies that have been conducted with a very strict criteria showing that the drug works. This doesn't mean that the orange ones are not suitable and cannot be used suitably with the patient. Let's move on. There are also non-pharmacological prophylactic treatments, such as psychological treatments that can give advantages, like behavioral therapies. And all of this is based on pharmacological studies, but there are some limits, some biases. For example, there is the exclusion bias because patients with comorbidities are excluded, and this could lead to an underestimation of the benefit of a treatment or some adverse events. Some comorbidities, for example, make migraine more serious, some other instead to the contrary. There is also an inclusion bias because there is a prevalence of female gender, and this means that clinical studies should consider, for example, the use of contraceptive methods because a lot of women relate this condition to the use of contraceptive methods, or this reduces the effects of other medications taken for migraine. Moreover, endpoints are not always uniform because all the trials had to, as the only endpoint, a response rate of a 50% responders. And also there are limitations in the measures of impact. For example, MIDAS is a good measure, but there is a limited application because there are some parameters that might emphasize the impact in some categories, whereas they might reduce, let's say, the impact in other categories. Let's move to the next slide. Other limits, limited follow-up, so because there is a reduced ability to assess long-term side effects or long-term side effects of these therapies. Moreover, there is a high level of complexities. It's almost impossible to with sponsored studies, and there are some drugs that are orphaned because we know that they have an impact on migraine, but considering that there are no clinical studies because maybe there is no interest in promoting them, we cannot use them in the treatment of migraine. Then the trials for all the drugs are not comparable in terms of strength and evidence with the current ones. So several drugs that have been used for several years have a lower scientific evidence because they can be compared with the most innovative one. What is the therapeutic gain of the prophylactic treatments? This means that if there is a response of at least 50% to the treatment, well, in this case, in some cases, drugs were used, in some other responses were used. And clinical studies show that migraine, about 30% of patients responded to placebo. This is a response. So if a drug has a therapeutic gain of 30–40%, the percent of patients responding would be around 70 or 80%. So all these drugs actually work on a wide range, a wide category of patients. If patients do not respond to a medicine, they might respond to another. This is why we need to consider the how refractory or resistant a patient is to the different medications. The medications must be used in accordance with the advantages given by other comorbidities or the disadvantages. This is a table that some colleagues in Bologna have created, and this can be very useful also from a practical point of view. Why isn't treatment effective? Because there's a percentage of patients that do not get any benefits, does not get any benefit from the use of these drugs. In some cases, they are drug resistant or refractory. But we need to be certain that the right criteria have been respected in the treatment of patients, that the patients adhered to the treatment, because very often they abandon the treatment notwithstanding the recommendations. And so if they stop taking medications, it is clear that they are not, there is no adherence to the treatment. And very often they decide to drop off, to abandon the treatment due to side effects. Some side effects are predictable, whereas some other are not predictable. In some cases, there is a nocebo response. In this case, if I'm convinced that a drug is bad for me, I will have bad consequences. This is the nocebo effect. And this plays a role in the abandonment of treatment. Or they can decide to stop the treatment according to their choice, because maybe they had unrealistic expectations. They are generally satisfied if we reduce by 50% the frequency of their episodes of migraine. Whereas if they do not reach this kind of percentage, they decide to abandon the treatment. Sometimes there are biases or the costs because, you know, drugs are to be paid, even though many of these drugs are affordable and have lower costs. But if we want to go for other kinds of treatments, they might have a strong economic impact on patients or other reasons that may be there. So to conclude, the therapeutic options we have had up to now are quite important. They are not poor, but sometimes there is not a strong scientific evidence, and this is not due to the drug itself, but for other reasons. The existing guidelines are an excellent means for, you know, setting the categories of therapeutic strategies, even though there are some lacks. It is always important to consider that there can be comorbidities in migraine patients, and they must always be evaluated and managed. Also at the same time as the migraine itself. And then there can be some adverse events given by treatment that should always be taken into account. But we must always consider that there is also the nocebo response. And if there is a lack of a treatment adherence to the treatment, this is one of the main causes of failure. So this is something to be taken into consideration. Thank you for your attention. Thank you. Thanks to Anna Ambrosini. Now I would like to ask Piero Barbanti, head of the campaign treatment unit of San Raffaele in Rome, to give his presentation. Thank you, and good afternoon. Can you hear me? Okay. So I would like to thank the colleagues, institutions, and patients of the Associazione Italiana per la lotta contro le cefalee, so the Italian Association Against Headaches, and in particular, Livia Giustiniani, who is in charge of communication for the association. I'm going to deal very briefly with the topic and by using a lot of pictures. So here you see this man crossing the desert, because it took 60 years to get from the first medications to the most specific ones. And I would like to underline a couple of things. First, drugs have been found randomly very often. But then we also required patients to be brave enough to follow their doctors and their recommendations. In the past, there have been very important centers created in Italy and then in the world. But I would like to underline that before 2018, the last medication developed in 2001, that is topiramate, was paid in liras. But in 2018, something happened. I don't want to say that we got to the promised land here with monoclonals, but I can tell you that we crossed the desert and we arrived in a city which is not an oasis. It's something real. In 2018, Irinumab, the first monoclonal, could be prescribed against the CGRPs. What did this new step forward represent? Well, I think this marked a turning point and a no way back, because there were 7,000 patients in phase A and phase B of clinical trials. Clinical trials allow us to be sure and confident that what we are doing is safe and effective for the patients. And so the results were very good. And another thing is something that our Prime Minister Draghi often focuses on. We need to consider the type of disease we are dealing with, and is it chronic? Is it episodic? Have there been failures in the past? We need to consider all these details. There are two colleagues here, and they suffer from cluster headaches, and hopefully there are some pharmaceutical companies that are studying drugs for this kind of problem as well. So we really hope that we will get two important results. But there's a new paradigm. There are drugs that are effective, that are not related to side effects because they can be used very flexibly. The problem is that selective molecules, biological molecules, are like handmade, and they are not produced at an industrial level, and so they cost a lot, and so the costs cannot be reduced a lot. So IFA, the Italian drug agency, set some limits. For sure, there are some countries in Europe that allow a wider range of patients to access this kind of drugs. In Italy, it's at least 8 days a month. Another requirement is that in the past, the prophylactic treatment failed at least 3 times. Then there is a disability with more than 11 in terms of MIDAS score. And then they also require control of the effectiveness after 3 months. So all other patients need to be treated with the standard therapies that we've used so far. Only those who respond to this criteria can be included in the use of the new drugs and therapies. As for monoclonals, if we think of the world of cars, well, they tell us this car runs 10 kilometers with 1 liter of gasoline, of petrol, and it gets up to 180 kilometers per hour. If we compare this to monoclonals, we can say that they are more effective with a higher level of adherence and tolerance. And so patients getting to headache centers, and I can tell you that at least 3 patients out of 10 responded to conventional traditional treatments, and about 8 to 10 had results with monoclonals. So 3 out of 10 against 8 out of 10. You know, again, the ministry set some guidelines, the 3 months follow-up. If we look at the different patient cohorts, patient groups in the various centers, we see that after 3 months, the non-responders were 38.6%. But most of them had a response after the 4 months. What does this mean? It means that if we limit monoclonals to the most complex patients, we give them more time to see if they are responsive or not.
Dicevamo un'epoca del non ritorno, un'epoca delle terapie selettive e specifiche.
I said that there is no way back. And will there be some new things in the next 12 to 18 months? For the first time since 1991 with sumatriptan, which was the first drug to switch off, so to say, the attack, we will have new anti-inflammatory drugs, selective and specific, that do not affect circulations. These kinds of drugs will be very important because their use is not limited to the 65 years old, to the 65 years of age. And these drugs will be extremely interesting for us as neurologists because they will only be neuronal. So focusing on the neurological origin of the mechanical effects. These drugs are the gepant and ditant therapies, and both cases, both drugs interrupt the attack, and in particular, gepants can even prevent it. So they cannot only switch off the attack, the episode, but it can even prevent it. And I think that this is a good, bright hope for the future. There are some buts, some cons maybe, that I'm going to mention immediately. You see here, there's a sort of superstructure of the brain that here is hit by monoclonals, anti-CGRP monoclonals, and then in the future, ditans and gepants. But this bears costs. So look at the car I mentioned earlier. This is a Ferrari Puro Sangue. I'm not a connoisseur, but this will be the first hybrid SUV of Ferrari. Great performance, great effectiveness, zero consumption. So similar to these drugs, a high cost, but a high effectiveness and no side effects. Considering this, we need to consider which kind of road we want to choose, the methods, the intervals between one thing and the other. But at the end, there's a pilot, and so the pilots will need to be trained. Here, there are Professor Berardelli and the most important representatives of Italian institutions and centers dealing with neurology and migraine, together with Cristina Tassorelli. But we need to consider that this kind of drugs really require the right training, the right training of our pilots. A few years ago, we thought that this was only a dream, whereas now it has almost come true. So we need to keep on like this to make it even more true. Thank you very much. Now let's move to Paolo Calabresi, Head of Neurology Foundation at Gemelli Policlinico in Rome. Good morning. I would like to thank Motore Sanita and the decision makers that were involved and that took part in this event. I'm happy to be here not only as the head of Neurology Foundation at Gemelli, because we deal with a lot of neurological disease, such as the most complex or the most frequent ones, such as strokes. But I'm here also as a president of the Italian Association of Neurology. This association gathers more than 500 neurologists. It is an interdisciplinary association. It works in close relation with the Italian Association of Neurology, and 50% of our members are young doctors. And this is the important thing that is actually in line with what has been said so far. Because, you know, we need to consider two main messages. First, the work carried out by SISC, the Italian Association for Headache, should focus on two main points that have been dealt with in these presentations. First is the culture of headache, and secondly, the fact of speaking in one single voice. You know, because if we do not join our efforts, we cannot reach out to the stakeholders in the best way, or reach out to the decision makers. Having fragmented initiatives would be negative. It should be coordinated. Our association has around 15 regional sections, and there neurologists work together very closely and work with the region. They represent a study center because research is fundamental, not only in terms of medications, drugs, and we got to impressive results in this field. But research should also go hand in hand with university. In Italy, there are maybe the best European neurologists, and Professor Berardelli knows that if we consider the investment in research and in scientific productivity, we are really among the leaders in Europe. And the scientific community has presidents of the International Headache Societies, important representatives at the European level. But, you know, talking about a culture of headache means to raise awareness to our doctors, neurologists, that need to be able to distinguish a primary and a secondary headache when somebody accesses the emergency, when they arrive to the hospital. This is fundamental. And then having some specific structures to collect data in the best way for scientific research. And there is an important study center in our city. The neurologist dealing with stroke or movement disorders receive some specific training. So we need to have something similar for this kind of disease, which was like, you know, the Cinderella of neurological diseases. And I think that both in case of emergency and in case of chronic disease, we need to have this culture of headaches and have a very strong one, not only for neurologists, but also for GPs, general practitioners, or for chemists, you know, specialists that have the chemist shop just outside our homes, because they need to be ready on this. There must be a culture of headaches, and there needed to be actually, there was this kind of culture also in the past among some groups, and it's important that it gets more and more widespread. So let me conclude very briefly by reminding you that headache is not only related to the problems of adults, It's very common also among children. So we need to have an exchange of points of view with pediatricians. And there is also a great comorbidity with psychiatric diseases. So that's very important that psychologists and psychiatrists are involved in our associations. Headache and migraines affect the elderly population, and it's important to make distinctions there. It's important to understand if this kind of headache is a sign of cognitive impairment or not in the elderly population. So it's important to keep on administering the right drugs, prescribing the right drugs to the right people, but we also need to have a spotlight on the culture of headache by raising the awareness of our pharmaceutical industries and others to study and develop the best solutions. And this spotlight in the past was like a little flame burning, and now it's getting bigger. And I hope that there will be a real explosion in the future, and maybe we will again cross the desert, as the colleague who came before me said. And like with all other neurological pathologies, we need to deal with this one that has such an important impact, especially on women in their most important age range when they have children, a family, and so we need to deal with that very carefully. I really hope that in Italy the law approved in 2020 will be soon implemented and become effective, come into force, notwithstanding that, considering that there are events at a national and international level that require our attention. But I really would like to invite politicians and everyone to make an effort and join the efforts. Use one single voice: doctors, researchers, patients, and decision makers. Thank you. I don't know if there are other Motore Sanita in Italy, but you should tell us, because this is a registered trademark. Now let's move to Paolo Martelletti. He's an associate professor of internal medicine at Sapienza University of Rome. Thank you for inviting me, and I would like to say hello to all doctors, politicians, and patients who are involved in this work. It is difficult, you know, to say something original, something different from what has been said so far. But there's one concept that has been underlined several times: the awareness of a disease. This is a strategic asset for all people who work in this field and for all the patients who can benefit from new therapies. It is important to have several voices, several ideas, but working together. And we should also bear in mind the third sector which will be fundamental in the future, not only in Italy. In Italy, for example, our awareness is quite important. A lot of people got to know about this event on the ANSA channel. And so there's a whole channel devoted to this disease. That is a clear sign of awareness raising. Then, everyone deserves the right access to therapies and to the right treatments, but only a few can do it. And why this? Because there's a lack of information, and there are important barriers that together we need to tear down and remove. Then research. Research has been mentioned several times. I think we should be proud because in this field we are one of the leading countries on basic research and clinical research on headaches. So there is an important journal in the world that was born within the Italian Association for the Study of Headaches, and it is a leader at a global level and has been a leader in this field. Thanks to this, we can disseminate any kind of important research and studies. Before next summer, the new guidelines of the European Headache Federation will be published on the use of monoclonals, and an international panel put them at the forefront, was brave enough to put them at the forefront. We should not wait. This is something that happens very often, but we should not wait patients to become chronic patients or have other diseases, you know, before treating them. This is something cruel. The very last point is training, the training of specialists. There are scientists, presidents, heads of associations. So we should involve all of them in the training of specialists because we do not have enough of them. There are over 200 centers in Italy, but as other colleagues said, only 70 are really operational. So let's remove, you know, the centers that are not fully operational or fully effective, and let's replace them by benefiting from the help of people who have been trained and specialized. Our country is at the forefront, but I think that we shouldn't even mention this kind of thing. We should be ashamed of what happens. For example, also other diseases such as diabetes. Well, diabetes are everywhere. Diabetes centers are everywhere. And why shouldn't we have centers for headache? That's a shame, in my opinion. So, how can we achieve all of this? There are university masters or postgraduate courses. They are important, but they are niche courses. I think that there should be some lifelong learning carried out at the regional level in order to attract young people. For example, young doctors should realize that 4% of the accesses that we have at hospitals due to non-refractory headaches, well, when these kinds of cases arrive, they are not prepared enough. And I'm not only talking about neurologists, but also other kinds of specialists. And scientific associations should work together with these centers and try to, you know, maybe reselect the centers on the basis of the performances that they achieve. Because again, 200 centers and having only 70 of them fully effective, This is nonsense. Thank you.
Grazie, professor Martelletti. Elena Ruiz della Torre, I invite you to present the EMHA survey that could be the main benchmark for the call to action for each country, European country. Elena, please. Dopo parlerà Angela Seitz, che però è presente ma parlerà in un'altra sala. Perché farà
Angela will speak later. Elena?
Good morning to all of us. Thank you very much to all of us for being there. I'm so awfully sorry to have caught the virus, the COVID-19, 2 days ago, and not to feel okay to go or to be there. I think I would like to congratulate the Italian patients for the high level of doctors that there are in this country. I think we are participating in an extremely interesting meeting today. Both policymakers and neurologists have said everything we need to know, everything we have to say. I'm not able to read now because of this, the fever and so on. I'm going to let my colleague Angela to tell you about our researchers. And I will just put you some questions at the end of the speakers, because I really think that there are very interesting things said and further information that we would like to know. But let me give the floor to Angela, and she can first of all present you the data.
Oh, no, sorry, I was in mute. Hello, everyone. So from EMHA, I'm going to present now the results of access to care. I'm going to share the screen. Okay. Hold on. So the survey consisted on almost 3,400 total answers, from which 402 are from Italy, and within 4 modules, the content. So the section 1 about yourself, okay, social demographic data. Section 2 about your migraine, okay. Section 3 also about your access to care, so access to healthcare professionals, to treatments, and the impact on patients' life. And the 4th module is on sources of information. So information about the general disease and migraine treatment for patients. It's been done in 10 languages, okay, and up to a specific date, but then 2 more languages were launched in April. The results of the respondents have been women between 25 and 59 years old from urban areas, okay, and actively working. Here you have this data of urban areas actively working. And main indicators relate to the type of migraine evidence is on 58% of chronic migraine. Okay. Something to also note is within Italy, 14% have daily migraines. So when patients suffer an attack, migraine is very disabling, and it affects your daily routines when suffering an attack, I insist. Otherwise, you perform normally. And from the survey, we noted that the activity where patients needed more help and support was driving, okay? Also, you can see like getting medicines at pharmacy on here was also quite notable, but definitely driving is the conclusion. On regards of visits from patients to specialists, so GPs is the weight is the importance for the first visit, and then neurologist is the most common specialist diagnosing migraine. Okay. Here you see 54% as GP on the first visit. On the next row, 18% have to visit even more than 8 specialists. Okay. The third row, 49%. These are all Italy data for the neurologist. And then also we would like to point out there's 22% that do not have a follow-up. Okay. The access to specialized migraine centers is really good in Italy. In the case of 70% of patients are treated. And as per the Italian Society for the Study of Headaches, in Italy, there are 83 centers for the treatment of headaches and migraines. Based on also some input, first treatment received are general analgesics, and the last ones are the antibodies. With here you see on the 6th visit, first visit the analgesics here in green on the first bar, up to the 6th visit we have 24% for the anti-CGRPs. So when assessing the current treatment, again, we observe triptans are widely used, and around 30% of patients in Italy are receiving Botox or the antibodies. So although 60% reported to have an impact on their finances, only 20%, as you see here on the bottom right side, 20% only ask for a treatment change. Okay. So the impact on cost for treatment of 60%. So although almost 90% of patients are treated, time since diagnosis is really evident. So there are difficulties. So in average, as you see, almost not, so 84%, almost this 90% of migraine patients are treated in Italy. However, the years since the diagnosis is done to receive the migraine treatment is over 5 years. The antibodies and Botox are reported like the most difficult treatment to get. And the main reasons, as you can see on the right side of the chart, is because it's both not covered by healthcare system or by the private insurance, or even in those migraine centers that we've mentioned before are available in Italy, this new treatment is not available. So as a summary of the conclusions, the majority of respondents were women between 25 and 59 from urban areas and actively working. 58 of respondents suffer chronic migraine in Italy. And the patients suffering from severe migraine are 67%, with more than 8 days of migraine a month. And they suffer it for many years. Okay, 91% of them suffer it for more than 10 years. Patients also reported that migraine affects their daily activities, mainly, so when suffering an attack, of course, and where they need most support is while driving. First visit specialist is the GP in Italy with 54%. And then the main specialist who's making the diagnosis and the follow-up is the neurologist, okay? Noting that 22 of those respondents are not being with a follow-up by any specialist. Although almost 100% of patients are treated, the time since the diagnosis is made until the treatment is obtained, that time evidences these difficulties that we've been mentioning. So 53% needed more than 3 years since diagnosis in Italy and 49% in global results. Since the diagnosis, the first treatments received are general analgesics, followed by triptans, and the last ones that are prescribed are the antibodies. In Italy, 74% triptans are used, and the least used, Botox, it's 5% in Italy. Also, polymedication is highly frequent, and multiple drug combinations have been reported, being a specific prescription together with antibodies or painkillers. And topiramate is the main received. And finally, Botox and the anti-CGRPs have been identified as the ones that are most difficult to get access to in Italy, and the main reasons, as we've mentioned, so because the product is not available in these specialist migraine and headaches centers, and also because it's not covered by private insurance or public healthcare. And yeah, this would be the conclusions from my side. And any questions, Elena also is available to answer.
Okay, so I think...
Grazie, grazie.
Thank you so much. Absolutely, thank you. Very interesting presentation. Thank you for this interesting survey that you've carried out. Now, this is an incredible encouragement and spur in Italy, but this is also a great benchmark for many other European states. So access, I have to say, pardon.
Yes?
Yes, please go ahead. Yes, yes.
Yeah, thank you. Thank you. 1 second, just only second. I want to point out that the best and most innovative treatment in the market is useless if there is no access to it. And we have new treatments. We already have specific treatments for migraine. We have been years and years taking so many other preventive and acute treatments that were not designed or tested for migraine, but they used them for us because there was nothing specific for us. At this moment, there is one specific treatment for migraine with no side effects. We know how many poisons we have been taking for years. We really need access to this new treatment. Those people who answered the survey in Italy, this 90% of the respondents that said that they are treated is because we organized this survey through the Italian Patient Organization, which is an extremely good one. You will hear now, you will see now the president, Lara Medici, and those people are experts on their treatment of the migraine. They are mostly of them chronified people, and they know very well what is to be treated and what is to spend 8 years of their lives going from one sitting room to another sitting room, looking for the best and specialist on migraine. So if at this moment there is one specific treatment, let's give access to it, please. And this is my request and call to action to the policymakers, because you could do something. There is a big pointer on budgets, on approving budget for those treatments. Our specialists, they need to have the budget to buy and to get those treatments for those patients who need it. So this is, I just wanted to point this out because I think it is important. Research is very difficult, it's very expensive, but when it happens and it comes out to a new treatment, let's use it. Let's make it accessible for patients. Thank you.
Grazie, Elena.
Thank you so much. You know, this is a big problem, access to drugs, that this is not just a neurology problem. In our country, we have some regions that, are ready. In some cases, there's a delay because, for example, when AIFA has approved the drug, we don't know why we have to have permissions to access the drug. So the difference is between one region and the other, not only in terms of neurology, but also in oncology. I'm now asking Daniela Moruso, and together with Alessandro Malpelo, if I'm not mistaken, to continue once again with the, let's say, moderation and chairmanship. So, disability, chronic migraine. We are landing a little late, but please, 5 minutes each. Okay, thank you. I'm the coordinator of ASCO Italia. No. Good afternoon, everyone. I would like to wholeheartedly thank Motore Sanita. Also would like to thank EMHA. So, 4 associations, you are our northern star. I also would like to thank doctors, GPs attending. Well, you are 50% of the entire therapy. Sorry, the mic went off. I'm sorry, we cannot hear the speaker, and I see that there are many messages in the chat, so you are having the same problem, sorry. Okay, just waiting to switch on the mic. Okay, here we are. Dr. Rossi said, a society that wants to remove pain behaves as if pain didn't exist. Sorry, the mic is off again. I would like to thank the operating group from the CIRNA Foundation. We also have a forum in the Italian site. We are on Facebook and Instagram. We also have self-help groups together with support groups. I've been doing or offering support, online support So people who ask me to talk about their suffering, so their headache. We offer active listening and understanding. Hopefully, this will lead to a change and to transformation that includes acceptance. We need harmony, we need peace, peace of mind. What is difficult is maintenance of the positive situation is difficult. Our site is visited from all over the world. We have thousands of visits. So this is our question. Is life possible with a headache? This is a very difficult question. Sorry, we have huge audio problems. We usually think of the life we cannot have, and we cannot think of the life we can have. We forget it. We forget what we can have. This is a young woman telling me, Tara, you have to highlight that for us, there is no quality life. We heard about this morning, and I'm sorry, it's a pleasure for me to share this with you, and I'm also glad that you are recording this conference. Your words will be a precious solution for our life, like an ointment. In red, you can see a sentence pronounced by a medical doctor, a politician, in the city of Ferrara. I was attending. One of our colleagues was, working to recognize a chronic headache as a social illness, and that was 2014. I remember it was February the 9th of 2014. You can find the video if you look for CCF. This person said, what cannot be measured doesn't exist. And then she said, what cannot be measured doesn't exist. This is what some people dare tell us. Some people say you don't have headache. Sorry, my cough again. If you don't think of it, it goes away. You women, you are too complicated. Everyone has a headache. Your headache is an unconscious alibi not to face problems. Wear glasses, which is what I did, it will go away. Get another job. Maybe you're not happy now. This is what people told us. Have more sex. You don't respond to the prophylactic disease. You are symptom-free, as if it was my fault. I felt guilty. There are news we can read on the newspapers telling us how to solve a headache. Two more pieces of news. You read this and you think that there's plenty of solutions for us. This is a page of a newspaper. You can see the pharmacy sponsoring a drug. It was Valentine's Day, so that night it was impossible to have excuses in order to make our husbands happy. This is a shame because this is a pharmacy. I did the impossible to do something, but no one did anything. Sorry, too many people speaking and too many sheets of paper are being shuffled on the desk. We cannot hear. I'm sorry because all the mics are on and we hear voices and noises. Please send a message in the chat if you are listening to us. It's really impossible to hear the speaker with all of this noise now. Really sorry. And now the mic is off.
Io ad avere mal di testa alla scuola materna. Quindi noi dobbiamo intervenire sulla scuola. Io ho persone arrivano a 18 anni.
So we have young people coming to us. I have contact with people. We do support to young girls. They are 18 and they are very chronic. Safety. I had to have my homework done. This is what I did very late. And if you don't know what headache is, you cannot understand this continuous sense of unpredictability and precariousness. So a nice day is always a day that has a price to pay. I don't want to give up because I have a 5-year-old daughter. Otherwise, believe me, okay, we can continue. Okay, back one, please.
Torno indietro, leggo da qui, scusate, ma ecco, chi non sa cosa sia mal di testa non può capire questo.
If you don't know what headache is, you can't understand this sense of precariousness and unpredictability. A nice day is always a day we have to pay so much for. I've taken something to alleviate pain. I don't want to complain only. While I'm writing, I'm crying. So these are messages that girls or young women sent me. I don't give up. I have a 5-year-old daughter. Otherwise, believe me, I wouldn't accept this life with plenty of problems at the workplace, even if I've been hired in the so-called protected category workers. The effects of our life, well, pain and fear, they are the masters of our life. We never feel safe. They sleep inside of us and they explode whenever they want, just taking away all of our thoughts. 10 days ago, 10 days ago, I attempted suicide with my drugs. I just wanted to stop suffering. I wanted to die because I didn't want to feel all of this pain. This is something that's happening to me. This is not me. I don't think this is me. I have, I guess, a parasite inside of me. It uses my body. It takes my body, and I'm becoming what I am not. This is also a long sentence I always remember. This is Piera. So if you suffer from another disease, when he or she tells us what he or she can do, well, everyone says, wow, excellent. So you are reacting. And you know, because she managed, to go through cancer, and she was told that she was accident. If we say the same thing, people say, come on, oh, you don't look miserable. I feel like an explosion in my head. This is what we say. And what also explodes is the soul, together with all what we have wanted for us and for our family. A headache is representing all of our suffering, including the soul. It is difficult to have visits, to go to the doctor. This is what we are told. When we call, for example, for a visit, the doctor says, I can't see all those who suffer. You have to come here. I can't accept, reservations by the phone. Please call tomorrow or maybe another day. You have to call the regional center, but, I don't remember the number. We have beds available in 12 months. In 2 cases, I tried, in 12 regions. In 2 cases, someone told me, what are you doing there? Please run here and I will see you. And the other doctor said, and I didn't understand. He waited for me 1 day earlier, and he waited for me 1 day before I recalled. When the patient speaks, listen to him. He is suggesting the diagnosis and the care. What I tell patients is you have to educate yourself and you have to help your GP to plan the treatment for you. If you sit in front of your doctor and if you say, please help me, you are just getting ready for a huge quantity of pain, because this is what happens. We have to do what we know in order to help the drug act, in order to help GPs or neurologists to take care of us in a better way. This morning I went to the hospital pharmacy to get my monoclonal dose. I'm so lucky. It's a privilege for me because I can take care and I can use this care. It has revolutionized my life after 40 years of pain and frustration. Headache, well, this is a companion, but I am not the target. Sometimes I can live. Life is so beautiful. Today it's a sunny day. I'm not in bed. I am enjoying this beautiful sunny day. Future objectives we have. So thanks to the decrease we talked about today since November, I have started, stalking politicians, which is what I did from 2007 to May 2020. So that in their agenda, they had to acknowledge or recognize chronic migraine as social disease. I have sent them 1.1 million emails from November to today. For the decrease, I have already sent 25,000 emails. I will never stop until they approve the decrease. This is really, really moving. I think, we are going through hell. This is hell.
Perché torniamo indietro per cortesia. Ecco.
Dobbiamo avere spazio,
allora, avanti,
dobbiamo avere lo spazio per far parlare 10 persone.
Parole che aiutano.
Let's go back to the previous. So we need to know and understand our pain.
Grazie, grazie mille per la gestione del timing. Laura, sì. Appuntamento al consiglio d'amministrazione. Sarò a Milano per il consiglio. Merci. Très bien, merci aussi de mon côté. Merci aussi de nous avoir permis de participer. À mercredi prochain. Bonne journée. Merci, merci beaucoup à tous et à toutes. Au revoir. Au revoir. Merci, au revoir.
E bisous bisous, baci baci.
Sbagliata per notare il ritorno. Sì. Ho preso 2 volte un'andata da Reggio Emilia.
So we need to have hopefulness and enthusiasm because
No,
nobody
era alle
else
14,
is
devo vedere
responsible
se
for
riesco a
our
modificarla
happiness.
cambiando le stazioni. Non so
As
se
Victor
sono-
ago said,
Ho preso 2 andate.
remember that
Cioè il ritorno l'ho preso
smiling is like
Reggio
the
Emilia
sun
V Milano.
that
Quello delle 14
keeps
anziché
going far away.
14:05.
No, certo, certo,
Thank
essere
you.
partita già si può.
Non lo so.
Sì, sì, sì.
Posso
fatto
cambiare la
for
stazione?
this,
Cioè invertire le stazioni? Non lo
No,
so.
no, no, chiedi rincorso, cioè non lo usi più.
Non lo so,
for
sì.
this
Sì,
precious
sì, sì, sì,
contribution.
esatto. Adesso hai preso il super economy, super
No, no,
economy.
l'ho comprato col
Like I
carnet.
said, we need to
Sì, sì, allora sì, devi
access
telefonare però.
innovative
Devo
treatments.
Io le faccio una
telefonare.
volta di
That's
carnet, poi
the
dopo sono
right
spaccato,
way
perché,
to
scusa, ma te hai il
go.
carnet a Bologna?
And so
No, da Reggio.
this
Ma sei in Italia? Ah, appunto, perché Italia non lo fa.
No, infatti
Dr.
no.
Claudio
Ma che
Altamura,
strano. Dai, ce l'abbiamo fatta,
Grazie
Francesco
infinite.
Grazie.
Grazie.
Dai.
Sì, è andata meglio
Finocchi.
rispetto alla scorsa
Sì,
volta.
per me l'impianto era... Noi abbiamo detto tutte le volte che insomma avevamo
Franco
gli occhi là,
Granella,
si capiva insomma chi era, però
Laura
alla fine tu era
Merighi
crudele
and Giorgio
Sì,
Santini,
Gianna
non
Cristina
c'era
Tassorelli.
infatti.
però forse il sistema era diverso perché vedevamo
Together,
voi reagire in modo
Sì,
diverso.
we
no, ma te l'avevo detto le altre volte.
Dobbiamo costruire questo percorso veloce e già quindi invito la dottoressa
Erano proprio
together
alternative.
have
Per
tornati
cui...
alla
Dr. Claudia Altamura,
Perfetto, comunque appunto
neurologist
qualsiasi
at the
cosa
Headache and Neurology
notiate
Unity
nel
of the
corso
University
di c'è
Hospital
sempre
Biomedical
punti di
Center.
miglioramento che arrivano per
certo,
noi,
vabbè,
per
ma
cui
questa è una cosa standard.
This
Noi
is
non è che stiamo
something that
utilizzando
we need
quello che diciamo quando c'è
to
qualcuno
from this
senza microfono, ma
survey.
sì, esatto, certo.
Ma siete anche talmente poco numerosi, siamo abituati a quelle conferenze,
Sì,
sai,
sì,
con
sì,
100
certo.
speaker e quindi
To
succede.
No,
Qui ti viene
infatti.
forse anche
English.
naturalmente, no? Prendi la parola e...
Perfetto,
Però
dai, allora
e poi tantissimo tempo ancora per poter avere quelli che il il professor Barbanti ha detto.
Professor Barbanti said that we need specific drugs. Well, I'd like to ask a question, because we got to a sort of paradox because we needed to use some standard therapies for headache. We have always told patients that we chose therapies according to their comorbidities and situations, whereas now it's like a paradox. It's the first specific therapy for headache. And so it's the paradox because it's the easiest to be prescribed. So from an ethical point of view, is it right to limit the prescription and the possibility of prescribing drugs to just a few centers? Because, you know, that would be the easiest thing to do. And then another thing that I wanted to ask has to do with patients suffering from headaches and the fact that there's a sort of fight that they have to have because sometimes they are angry because they don't know the cause of their headache, and so they come to us, and they are like aggressive, and it's normal because they haven't received the right response. Well, we will ask Cristina Tassorelli to answer these questions, so thank you for that. But now, let's move on with Carlo Borghetti, Vice President of the Regional Council, the Third Commission for Social Policies and Health of the Lombardy region. Can you hear me? Yes. Good morning. I listened very carefully to the various presentations and testimonies. I can tell you that I am a witness because I have suffered from migraine in the past, or better, cluster headache in the past. Luckily, I haven't had it for a few years now, and I cross my fingers because, in the past, I had it. I started at high school and again at university, and then I got, to my work in life, and luckily I didn't have to deal with that anymore. So again, fingers crossed. But I can tell you that I'm both a patient and a person working in the institutions, and some of the things that have been said are crucial, and we need to take them into consideration, especially at a political level and at an institutional level. We must bear responsibility for that. And one of these things is the fact that patients have to know the things that are available at a local level for them. And this is important, especially when they go to their family doctors or specialized centers. For example, talking about my personal experience, only at the end of the second episode of cluster headache, I was referred to the neurological center for headaches of Milan, and they solved my problem with an innovative drug, but quite a strong one. But I had been waiting for over 1 month. And so sometimes there's a lack of knowledge because, family doctors, general practitioners are a fundamental category, and I think that they are doing their best, but they should be made aware of the innovations existing in the kinds of treatments available. So, like refresher courses, training, these are essential things for them and for the best treatment for patients. The best center that prescribed that medication to me actually improved my life and improved my condition when I had attacks. Innovative drugs are not always fully supported, and even when they are available on the market, they are not used say broadly enough, widely enough. So there are two main goals to consider. A very last thing, we should remember the so-called Casa della Comunità, so houses, community houses that will be implemented all over the world. It is clear that we cannot have headache centers in any of these houses, but we need to consider that these houses will need to deliver services, and there should be a percentage of headache centers at a local level. You know, this is closely related to the difficult integration of healthcare systems at a local and national level. But this is important. And this should be done in order to keep people closer and keep people closer to institutions, benefiting from whatever medicine makes available to us. Thank you. So that's another, witness. And we should also remember that 1 man out of 16, 1 woman out of 5, 1 family out of 4 is affected by the problem of migraine or headache. But unfortunately, access to treatments is the real problem. Dr. Geppetti, Pierangelo Geppetti, Director of Headache Center at Careggi Hospital in Florence, he wanted to add something. Yes, thank you. The problem is mainly related to the access to really effective drugs. Italy is maybe the country that set guidelines before anybody else. And in these guidelines, there are several medications. Some of them are more effective, some others less, but they generally belong to a different era, a different period. So something related to what Professor Barbanti was said. Guidelines are talking to specialists in a way, whereas maybe we need to switch to a different definition, that is diagnostic and therapeutic paths or processes involving general practitioners too, involving patients associations, involving institutions, because we need to get to the diagnosis first of all. Dr. Altamura was saying that headache centers are few. Well, there are more centers in Italy than in other European countries, so I don't think they are few, but we need patients to get there earlier, and so reduce waiting lists, make procedures more flexible, and also avoid some barriers that are existing. We talked about 3 failures because before getting to the most efficient therapy, you know? Do you agree? Well, I agree with what you said about this fact of the 3 failures. I think that this is a contradiction. And I want to point out something that is in line with the question that you asked. And this is the patient's journey or patient's path, if you want. In Tuscany, some years ago, we devised a sort of path for these kinds of patients, but actually it was very difficult to put it into practice in, administrative authorities or in other healthcare centers. And why this? Because what we have in Italy, the CUP, so it's the system in charge of reserving, booking tests for patients, that is sort of intermediary between the doctor and the patient or the headache center. And that's the weak chain. And sometimes it's difficult to put into practice what you think would be the best for your patients. I would really like the so-called community houses, as we call it, in Tuscany, become a structure that is closer to the patients and closer to their needs, and not just some administrative authority. And to conclude, well, we have a lot of centers in Italy, centers that can prescribe monoclonals, the best therapy for patients. You know, when patients get to the centers, I think that they have already failed, unfortunately, the treatments with other drugs. But these centers are important because there is a specialized nursing care, and there can be an interaction. There should be an interaction, whereas now they need to fill in forms, get to their GPs once, twice, 3 times, and this really is demotivating for specialists. They sometimes find it difficult to embark on this procedure. Professor Geppetti, sorry for interrupting you, but I think that this is the paradox of a country which is actually advanced in terms of research, with the best, journal, with the earliest guidelines and paths, but then dealing with administrative or other kinds of difficulties. Now, I would like to invite Professor Granella, Vice President of the Italian Association called CISC, and Clinical Director of the Department of Neuroscience at the University of Parma. We are a country that needs to tear down a lot of barriers. We have defined a good law, the Law 81 of 2020 that was approved on the 14th of July in 2020, was really like the attack to the Bastille, an attack to the prison where all patients were trapped, all patients living with migraine. So it was like a prison and we attacked it, but we were stopped by a lot of barriers. These barriers are the difficulties that Professor Geppetti has just mentioned, this bureaucracy, administrative procedures. Why not to recognize immediately that we have some effective therapy that we might use immediately? Well, I think this is our national peculiarity, unfortunately. We are sometimes very good and performant in some fields, but we lack organization. We have a lot of administrative steps to follow. So even a neurologist specialized in headaches, working in a center on their own, sometimes renounce to use the drugs for the patients because maybe it's too difficult or it would take too long. And it's clear that there are barriers for doctors and barriers for patients. Again, I would like to underline once again that the first barrier is awareness. If you think of Emilia-Romagna, even patients didn't know that they were patients. They were migraine patients, I meant. And then another point is the fact that, again, this is gender related. There are a lot of women and young women suffering from that. And all these people should be treated by, first of all, family doctors, but family doctors have not received the right training, and they do not have a proactive approach. I'm convinced that the innovative drugs that we have mentioned should be proposed immediately. Maybe it will take time. And I remember that when 30 years ago, there were innovative antidepressants and there was a very long procedure at the beginning, but then in a few years, things have changed. Please stay with us because you mentioned the costs. So economic resources, this is the other barrier, the cost-benefit ratio. Francesca Puttura Bernardi, who is the director of Polyclinical Vitelli Naples and of its pharmacological department. Well, Dr. Bernardi, would you like to say something about this cost-benefit ratio? Can you switch on your microphone? Can you maybe open your microphone so that you can tell us something about another region, Campania? Good morning. Well, that's the point of view of a person at the head of a pharmacy. I think that the cost-benefit ratio, the cost-benefit analysis becomes the most important thing to consider. As for innovative therapies of migraine, this cost-benefit analysis is a barrier, actually. How can we overcome it? Good morning. I'm here on behalf of Dr. Ugo Trama, director of the pharmaceuticals area of the Campania region. He was one of the first people involved in this in the Campania region because they created a plan 2 years ago, a PDTA, and it was implemented. And then we defined a sort of roadmap for the various centers to have widespread accessibility of patients. It is clear that we need to consider the cost and benefit analysis and we need to still do something to be in line with the national level to have a better access to these high cost therapies. This is true not only for migraine, but for other chronic diseases as well. It is important to prescribe the right medication to the right patient and at the same time ensure the sustainability of costs. So from the point of view of a polyclinic hospital, well, the assessment depends on the various costs that every department can bear. From a regional point of view, we are actually trying to organize a path. Well, we talked about the need to move from guidelines to train specialists with the guidelines and also train general practitioners. And this is a very difficult subject, a very difficult topic. There are lots of different names, and Professor Barbanti mentioned it earlier on. And there are lots of names of drugs that are difficult to pronounce, difficult to remember. So we keep on prescribing, you know, what Professor Barbanti said, that it is topiramate, that is an old one. And there are 20 years of difference. So, Professor. Well, I really appreciate what Doctor was saying about the what is being done at the regional level to make the procedure more flexible and quicker. But I would like to underline that there is inequality in terms of access. And so very often there's a general difficulty to access the therapies depending on where the people live. But remember that we wanted to improve the relationship between the regional and the central healthcare systems, but we haven't been able to define clearly the first, second, and third level centers. But I think that general medicine, general practitioners are the starting point. And there were other priorities, unfortunately, in the last 2 years, but the association, the National Association of Doctors, is working with us to promote initiatives to train and inform general practitioners, specialists, and the local health unit centers and universities, and all of this will have an impact, I hope, on the patients, not only in our region, but all over Italy. And they are involved in almost every round table. Thank you. Thank you, Dr. Bernardi.
So we haven't talked about the current perspective. And we can now have Mr. Castellucci from one of our...
pronunciato bene il nome dell'associazione.
Buongiorno a tutti, mi sia consentito.
Però abbiamo davvero pochi
assolutamente cercherò di contenere il mio intervento in pochissimi minuti, benché io l'avessi cronometrato in 8, ma lo taglierò. Però alcune cose mi sia consentito dirle. Innanzitutto voglio ringraziare lo staff di Motore Sanità e l'EMHA e tutti quanti hanno voluto la nostra presenza oggi qui su questo importante e delicato tema avente ad oggetto quello che tranquillamente possiamo definire il male del secolo. Faccio un piccolo preambolo su quello che è l'AUC Italia, è un'associazione di pazienti tutti sofferenti di cefalea a grappolo che si propone l'obiettivo di fornire a chi soffre di questo
give patients, so once again, our association works with patients suffering from cluster headache. Only people who suffer from this pain, well, they are the only ones understanding all what can happen. So this means we cannot explain the tasks typical of this age of our profession. It concerns everyone, and the most difficult thing for us, or time for us, is the night. So you have to understand that for a person who suffers from this pain like me, so I have to face a working day or a family day without sleeping for weeks. You are from Foggia. Do you have a headache center in Foggia in your city? Yes, I'm sorry to say that they don't have all the features that you have in Rome or in Milan. So we see that as a different, treatments offered, and the difference is striking. I mean, between North and South. So there's a negative influence of this pathology on the life of every one of us. Now, this is a fact. There's a negative impact. And this is what we all know. I mean, medical doctors, GPs, everyone knows that this happens, and you have to consider this. I have a short anecdote I'd like to share with you. I suffer chronically, and when my children see me suffering, I, of course, need to tell them that I cannot be father, and I have to recharge energy, which is contained into my oxygen container. So this is what I would like to share with you. So we have to deliver this important drug, so to say, because for us, this is fundamentally important when you have cluster migraine. So we see different ways, different behaviors from the different associations. Very probably this is due to the lack of awareness in hospital or even basic, let's say, medical centers. And once again, I need to say that, of course, I do welcome law number 81 approved back in 2020, but I need to talk about the lack of harmonization. So there are different ways, different modes in order to deliver oxygen, which is the most important weapon for us. I know that there's been plenty of research papers in terms of headaches, and I remember a master for us, Professor Raipuka, and then he taught at the university in Bari. Well, this is not Sicily, So as I said this morning, and this is what I've shared with you this morning, well, probably we are a little bit more advanced than these regions in southern Italy, but once again, we are lagging behind, just like the rest of southern Italy, especially if you make a comparison with some northern Italian regions like Lombardy or the Venice area. Now, this is something that we cannot accept because, once again, this has a major negative repercussion that this pathology has on our daily life. Once again, this is our, call to action. We now have another call to action. Cinzia Pinocchi is the NSF chairwoman. She is now coordinating and managing the department. So from IEPS San Martino, this is a hospital in Genoa. So we have listened to, the words of a person who has to fight on a weekly basis. Well, on a daily basis, with cluster headache. And we consider the new antagonists, CGRPs, as Professor Barbotti. Can we count on them for specific therapies? Because, of course, this is a specific peptide which is being targeted. And this is, from the trigeminous nerve. So are they really targeting the, if you will, the hardcore of the cluster headache? Well, the situation, it's a little bit more complex. Maybe for migraine, it's a little less complex. Specific words is much more, is much better, okay? Maybe not causal, let's say specific, okay? Specific is the right word. It is specific because, of course, all of this is targeted towards one of the reasons for pain. This is probably not the only target. We can build, specific therapeutical targeted drugs. And this is proven by the fact that even if we have effective treatments, we have at least 20% of non-responders. So for the non-responders, we have physiopathological mechanisms of many different types. We still have to explore this. So there's room for research, if you will. So as a specialist, you know that a patient may be treated with a specific weapon. So with a much better effectiveness. What is your feeling? So you have to tell him or her, okay, let's try with a drug first. Let's create a specific therapy based on the rules or the failures of the previous treatments. So if you have migraine or a complex form of headache, the solution is not just the prescription of a drug. First of all, you have to raise awareness, take up improving lifestyle. It's much more complicated than prescribing a drug. Then, of course, we have some regulatory limits, and in a way, we have to comply with this. But at the same time, we built a long pathway with our patients, including administering drugs. And maybe some of them had already been used in the past. This means we can speed up. But do not forget, many patients feel very well with traditional companies. So we don't have to throw away all of the therapeutical armamentarium available. We have to use this in the right way. We have to, comply with the interests of patients. Professor Finotti allowed us to understand that the most important thing is, once again, the take-up. So let's conclude with Alessandro Giuva and Giorgio Sandrini. Okay, Mr. Sandrini? Okay, here we go. Okay, thank you so much for this opportunity. I'll be very brief. We don't have much time left. Now, we are a non-profit making foundation.
Ben rappresentata da Lara Merighi, che è l'anima storica di questa associazione.
Laura Merighi is the representative of this Patients Association. We also managed to create a European association. Now, a couple of points I'd like to draw your attention on. The work of foundations, as Professor Mantelletti said before, this will have a growing, more important role. This is very important because, of course, we want to, enhance, if you will, the importance of patients and associations. So, as for the second point, I'd like to highlight another major role from associations. Well, I'm talking about helping political systems that, have to make a decision. So from this point of view, I have the pleasure to tell you that soon we will publish a specific consensus document, and this will be on an activity promoted by our own foundation. This concerns many criteria that may be applied for the definition of invalidity due to a headache. It's important to have laws. It is also important to enforce the law. So I hope that this is one of the many tools which is really important to implement. We will now conclude, giving the floor to a person representing people.
Diciamo così, vista dalla
pochissimo tempo, visto che è venuto anche.
Well, I will talk very briefly. I will be very brief. And I would only like to say, enjoy your lunch. Just one thing. I think that at a national level, having harmony, homogeneity is crucial, but it's something that we find very difficult. So that is my only final message. So, only a few words, but these words are significant because we have a task that is translating what we have said today in scientific terms and make it available to the general public. This is our role. For sure, this will have a strength, and I think that we should hope that today was not just an occasion to make analysis and have exchanges between institutions, doctors, patients, and representatives of the media. Because, you know, there was part of the conference outside this room, because there have been interviews in the hall of the venue, and you will see information about this later on. But what do we hope? We hope this event to have consequences, in a way, to have results and to encourage important steps forward, tangible steps forward. Yes, I would like to thank Motore Sanita because it was a very important occasion to exchange points of view among stakeholders, among the various protagonists. We listened to a lot of representatives from the world of institutions, from politics, and this is important because what we ask them, what patients association, professionals ask them all over Italy, from all over Italy, actually have to do with this diagnostic and therapeutical path. And this is why decision makers should take these demands into consideration and try to, you know, get rid of all those problems and difficulties. After the approval of the law, again, I said this earlier on and I repeat that, a lot of barriers remained. So we need these barriers to go down, paving the way, if you want, for quick and effective paths. This is a real call to action. We want all regions to work together in network in a fast, rapid, and effective way in order to take care of patients, to follow them up. Because, you know, it is important to have no regional differences and guarantee the best and most effective and most innovative therapy to all patients. So this said, I would like